Tonight we have John Kugler, Dr. John Kugler, who's here with us. He's a member of our community, so we're very happy to have you be here tonight with us. He is a he is a pediatric cardiologist. There we go. I'm always thinking about what Eric says. He uses the phrase pediatric pulmonology all the time because it's this alliteration. He just loves it. So, so I had to remember to say cardiologist, pediatric cardiologist at Children's Hospital, but he also teaches at UNMC, right, and at Creighton. So you've got like all the major medical institutions covered, I think. So we're very proud to have him with us tonight to talk about patient care as opposed to what would be the opposition?
I'm going to tell you.
Okay, well then he's going to tell you. I'll just shut up and let him do his part. Thank you, John. Here you go. Help me welcome him.
Thank you. It's a pleasure to be here tonight. We're going to run through some slides and then we're going to have some time, quite a long time, for questions. So let's get on. I have a couple of slides at the start that's the background, because I thought it was important to tell you kind of where this came from. So I started off with Institute of Medicine. Has anybody heard of the Institute of Medicine? Okay, good. So the Institute of Medicine was kind of born in 1999, so it hasn't been around for that long. But it's a private nonprofit organization that provides health policy advice under a congressional charter granted to the National Academy of Sciences, and it identifies for study and analysis important issues and problems that relate to health and medicine. It initiates and conducts studies of national policy and planning for healthcare and health-related education and research, and it responds to requests from the federal government and other agencies for studies and advice. And lots of experts belong to this Institute of Medicine, and this is where the concept actually started. So 2 years later, in 2001, there was a Crossing the Quality Chasm was the document that was put forth by the members of the Institute of Medicine, and they came up with what should our aims of healthcare system be. It should be safe, effective, efficient, timely, patient-centered. So this is really where it started. So the concept started about 15, 16 years ago, and it should be equitable. So I've color-coded patient-centered. Yes?
I just have one quick question.
Yeah.
Who funds it?
I'm not really sure. I think probably the government does, but I'm not really sure about that. So the Institute of Medicine defines patient-centered care as providing care that is respectful of and responsible to individual patient preferences, needs, and values, and ensuring that patient values guide all clinical decisions. So, to your question, Chris, earlier, what is the opposite? Well, it replaces physician-centered system. That's what it does. And it seems like, why wouldn't all healthcare be patient-centered? And it really seems like, where have we been all this time? And I'll give you some examples about it coming up here. But it really is one that revolves around the patient. So patient or physician-centered care revolves around the physician. So an example would be that a surgical procedure is graded by a score. We have lots of scores in medicine. A operation that comes out perfect, maybe it looks perfectly lined up on the chest, on an X-ray. It's like, what a great operation that looked like. It came out to be. But the score had nothing to do with what the patient experience was. So that's an example of physician-centered care. So patient-centered care revolves around the patient. For example, how does the patient feel? And that score, or whatever the situation would be for the physician involved, it doesn't come into play. is the patient satisfied with the experience, and how can the patient experience be improved? So this improvement, this patient-centered improvement, has been the root of improvement in lots of different phases of medicine these days. So an example of patient-centered care questions would be, in addition to how does the patient feel, is the patient satisfied with the experience, and how the patient experience improved, is what matters to the patient. It's a big deal. It's a big deal in terms of asking that question. You can get carried away with lots of care, lots of tests that are ordered in terms of what really matters to the patient. So the basic principle really of the patient-centered care is to realize that the patient knows best how well their health providers are meeting their needs, as opposed to the physician assuming that if the patient hasn't spoken up or said anything on their own or whatever, that it's just assumed that they're doing okay. But they are the ones who know how well their health providers are meeting their needs. And on the pediatric side, where I spend most of my time, for children, it's the parents who know best how well health providers are meeting their children's and their parent needs. So the question is, how can healthcare providers learn about patients and parents' needs? Seems like a fairly basic question. Number one, we can ask our patients and parents. So we move from what's the matter with our patients to what matters to the patient. Totally different way to look at how we provide our health care. So going from the healthcare providers need to ask our patients and parents, how about how can parents and parents respond? We need to, as patients and parents, need to proactively tell our healthcare providers what matters to us and how we feel. I think we are often too intimidated. We don't feel enabled. But a healthcare provider who is really providing patient-centered care will proactively involve and incorporate parents and patients into their care, and it just becomes automatic. But it's a total shift about how we as the healthcare people have grown up in the system to do this. So on the parent and patient side, if we're not well received, one of the advice is find a healthcare provider who follows patient-centered care principles. And it does take a lot of effort to go over to that side. I've been through it on a personal basis, and I can give you examples if you'd like to know more, but it is a paradigm shift in terms of how we have grown up into the system and find the way to involve our parents and the pediatric and patients on the adult side, involving all these principles. So what's the evidence that this works? Actually, there are voluminous research studies that have shown benefit from this approach. So if it's been shown that by many studies that if there's a positive relationship with the healthcare provider, we can have better outcomes. Lots of examples. Better preventive care. So in terms of prevention and all the preventive things that we are involved with. If you have a good relationship with your provider, you have better preventive care. Fewer hospitalizations because more prevention. You're involved to a higher degree. Other research, feeling of partnership with the healthcare provider has led to patients who were more satisfied, more enabled, lower symptom burden, they felt better, and lower rates of referral. So what does that lead to? Lower costs. So doctors, looking at the opposite direction, doctors who are not engaged in patient-centered care, who are often poor communicators, that's not always the case, but it often goes hand in hand. It's quicker and easier to order more tests when you are not communicating with the patient, more referrals. So instead of sitting and really becoming more enamored with the patient and the families, it can be much easier to refer to another more expensive testing situation. It's also been shown that higher utilization rates for diagnostic tests, hospitalizations, and prescriptions goes hand in hand with that. And patient-centered care can lower costs, therefore. There's lots of barriers. Yes?
Your mic went off.
It went off.
On the very bottom.
See if it went red.
Battery?
Push it to green.
No, if you touch it, it mutes it.
Hit it.
Oh,
by
I just hit it,
accident.
I'm sorry. So the barriers to patient care, patient-centered care are many. It takes a lot more time. A lot more time. And time is not rewarded. So there's a disincentive because you don't get reimbursed, and the patient the patient reimbursement situation with that time is a problem. Physician and healthcare providers are rewarded more by the number of patients seen as opposed to time per patient, so that's a significant barrier. Physicians and healthcare providers are trained in an era where more testing is associated with high quality care. The more things that you know is associated with testing. Well, we can do this and this and this, and pretty much it just goes on, and it's pretty easy to build up things. It's harder sometimes to know when not to order things. Physicians, healthcare providers are not convinced of value of patient-centered care. And I would only say that for the last probably 10 years and on a personal basis, that was where I was, and I have had personal experience within the profession of seeing most of what I have outlined today about how it's been positive with all. So I've experienced this, but it was an opportunity that I had, and I wasn't seeking it out. And a lot of people who are in the run of the daily life and doing the things that we have been told and in our training, it's not an awareness that comes up on a daily basis, so you have to really make an effort for it. And on the patient side, we are naturally timid. We're intimidated by the healthcare system. We come in and we are not knowledgeable about the care that we're receiving, and so often we don't know what questions to ask. So there's a barrier to that. So it's something that we all need to, I think, work on. So summary. Patient-centered care is a method of care that relies upon effective, empathetic communication. It's a feeling of partnership between physician, healthcare provider and patient, and it produces a higher patient compliance and active role with treatment. It's associated with improved patient care outcomes, higher patient satisfaction, lower level of patient symptoms, and lower unnecessary costs. So I can now have time for some questions. Yes?
So it sounds like you're saying that this is more of a philosophy rather than
Approach.
an approach. Okay.
Approach.
Is there, is this like a training that physicians can go through, or is it more of a, they make the decision themselves and?
It's not really a training, it's more of an approach that is moving through various forms of, or the various fields of medicine. And I can give you an example of, if you like, where I came from in terms of an example.
Yes. Okay.
Would you like that?
Yes.
So in my case, I'm a pediatric cardiologist, which means 90% of what I do, we take care of children who are born with heart defects. And there's a specific type of heart defect that babies are born with, basically 3 chambers instead of 4 chambers of their heart. It's called single ventricle hypoplastic left heart specifically, so the left side of the heart doesn't form. And it used to be decades ago that there was nothing we could do. We basically palliative care, and they all died basically in the first few months of life. And then surgeons and cardiologists got together and started doing some investigation and experimental surgery and staging. So we came up with 3 different stages of the operation. And over decades, the majority of babies can be saved and they go to kindergarten. We have some problems and there's lots of barriers in the way. But one of the first major steps was the first operation that's done. And it was a huge accomplishment. We got the mortality rate down to about 10% as the first stage. And then there's a second stage. And you go through this, all of this tremendous work on this first stage. And the second stage was much easier than the first stage, but babies would die suddenly at home. We'd get through all of this work and it was just devastating. And so centers around the world started really, why do these babies die in the what we call the interstage period? And we all would approach them differently. And we thought we knew the answers, and we started doing things as different centers all over, a wide variation of practice. We decided to form a collaborative many years ago, about 10 years ago now. And we decided about the time this patient-centered care came through, and we decided we don't know a lot of what we're doing and why we're doing it. Let's include parents in what we're doing. And we started including parents, and they come to we get together twice a year. We have 50 centers in this collaborative now across the country. We have decreased the interstage mortality rate from 18% to 6%. And we haven't done much more than including parents and helping them help us solve the problems of the interstage. And that's an example. And now we have all sorts of sub-projects that we do, and it's been incredibly, basically career changing in terms of being able to, parents like, why do you do this? And we look at each other like, why do we do this? And so they ask good questions. They're involved in their care. So that's my personal story, and I've been on the leadership part of this collaborative and including parents, and it's been great. So now it is generalizable beyond that. So parents who are involved in our local team, they come to our local meetings and where we do projects in quality improvement. they have spread out from the hospital. We now have parents on hospital committees. Because, like, why didn't we do this before? We're telling them, now they're telling us. It's just completely shift. And now the care is switched. We're doing this, and I think the outcomes will be better. And it's a good example in terms of the class. We have ordered lots of different tests over the years, and when parents ask us, well, why are you doing this? We had no data to say why we would do it. We just thought it was a good idea. And now we're cutting costs, we're involving parents with outcomes, and we've proven that outcomes improve. And so it's been generalizable beyond the collaborative at Children's Hospital here and across the country.
So is there like a master list of doctors that do this? Or do you just kind of have to pick, trial and error on the part of the patient?
Great question. So many parents are ask that question at our collaborative. So can we have the names of physicians who believe this and practice this? And we looked at, what a great question. And shouldn't parents also know a lot of information about the procedure before the procedure is done? How often does that really happen? Well, a lot of these babies now are prenatally diagnosed. And so they have a lot, especially in the big centers, it's not so much in a rural area like we have here, but they maybe have 4 or 5 different opportunities to go and see what is the best place to have their baby born at and operated on. And they're asking, why can't we have that information available? And we're working on it, actually. So I think it's coming. It'll be coming in different parts of the various fields of medicine as we go along. But as parents, they're asking that question and saying, well, we need this. And we're listening to them and say, you're right, you do need this. We all need this. So it's going to take a long time. It's baby steps. Excellent questions.
So
Yes?
you're a professor. Do you teach this as part of your curriculum?
Yeah. So, yes is the answer. So as a matter of fact, I have 2 lectures that I go through this to our residents in pediatrics, and I have 2 consecutive scheduled in January actually on this very subject. And the residents have been excited. So I had one come up after me 3 years ago or so and said, oh, I really would like to do a project. So I said, okay, come see me. So she did a project, and she flourished in it. She's really gotten involved with it. She devised a project whereby a protocol was made in conjunction with parents on initiation of feeding of these babies with hypoplastic left heart, because weight gain is an issue. And she did that as a first-year resident, and she decided to go into cardiology, and so she's going to be training in cardiology now. So that's an example. So I think people are being turned on to it, and they have to be exposed to it. It's a really good question, but I don't know if they're actually getting it in their medical school curriculum. I don't know that for sure. But I know in pediatrics in our group, we are. Yes?
If the system is geared against this, in the sense that they're not being rewarded for the time that they're doing with their patients, what are the odds that anyone's actually going to change long term? I mean, even if as parents or as patients we say, we understand there's this approach to medicine, and I really hope that you're the type of doctor that would approach medicine this way. I expect to be included in the conversations of here. would they actually be able to tell us that, yes, they do this and they do it boldly and they would include me? How do I know for sure?
Yeah, I don't know if that's answerable. It's a really good question. I think it's just similar to what I answered before. I think there's just the people that are out there and they learn and they become passionate about it, which I have, and I think they learn and they just pass it on. But I don't know if.
Well, is there any advocacy out there to change the system that they would somehow be rewarded for the time that they spent or the money they save?
Yeah, I don't think so, other than just wanting to do the right thing. It's in the aims of medicine. When you look at all those other 5 categories in the aims of medicine, they're all related. It's
so it's a value system.
yeah, it's a value system.
It's not something you can reward somebody for.
Yeah. It's mainly like seeing the results, which I've been fortunate to do. Yes?
Do any hospitals use this as part of the regular procedures, and if so, can you tell us which ones?
They're doing it in little bits and pieces. So how many of you are part of a healthcare system that you can go in and see your results? So we're getting there. I mean, that's just one small part of this, is that you're becoming involved in hopefully a proactive way. You see your results. Maybe that's going to prompt you to communicate how you feel about the results or questions. So that's one way. And some of the healthcare medical record system is doing that. And they got a long ways to go on a lot of the other electronic medical record issues, but that's one of the good ones. That's one of the good things. And so that's an example. I gave the example earlier is that there are hospitals that are placing parents and patients on their committees. And I think that's big, because it's always been from the top down, telling patients and parents what they should do or what they should feel, and they're getting involved with a lot of those things. So I think there are hospitals that are much ahead of others, but there are some awards, and I don't know what them all at the hospital level administration side, in which there is more patient-centered care activities. But since I'm not a hospital administrator, I don't know what those are, so I can't tell you. But it's moving.
It seems to me that the doctor I see seems to carry this, he seems to do this.
Great.
But I don't know if the hospital does this as part of the policy.
Great.
I
Yes.
have a couple of comments.
Huh?
This has been an area of interest. It's also a patient's responsibility to make sure this happens. And there's an agency called the Healthcare Research and Quality, AHRQ. And you can, ahrq.gov, I think. And they have a section for patients, and it'll give you questions based on your condition. So if you go in proactively to your physician and ask questions and see how they respond. Personally, and this was a long time ago, I was sitting in a doctor's office waiting to see him and grading papers on a teacher. And he said, "What is that, all from the internet?" You know, and I went, okay, because it's our response, it's us, we're the patients, and we need to take an active role. I'm kind of passionate about it. The other thing I wanted to ask, so the physician is, yes, but the staff, the people who take the appointments, the person who checks you in, all of them have to be of the same approach. So how does that happen?
Yeah, that's a good question too. In terms of our collaborative and the way our group, we're on it. We have a local committee. We meet, I'm the head of it in our group, and we meet every month in this collaborative, and we have a nurse practitioner, we have a dietitian, we have fellows in training that are in our group. We have parents We have a parent in Grand Island who is part of our committee that calls in, no matter where she is. She wants to be on our committee, and she has projects suggested to us by her as to do things along what we've talked about tonight. But you're exactly right.
Yeah. Well, there's that Think Health on the corner of 72nd and Center, which is supposed to be a patient-centered medical home, which is a home by family practitioners. That's one of their philosophies, and I've heard staff is not quite patient-centered, so.
Yeah, you need to be,
I've not
you should be,
experienced-
it works better when everybody's on the same page, no question about it.
Yeah.
Back to your, in terms of being advocates, and that's why I mentioned, it really takes effort and thought and process, and take your list of questions with you. The group that I'm working with, the parents developed in our collaborative, they developed a list of questions, and they, for prospective parents who are prenatally diagnosed with this condition, to take to their center and ask. And it's published and it's on our website, and so that's an example of what you're talking about. There's lots of efforts that are along those lines.
I had a question about, when you're dealing with children, you've got a person who can't make a decision for themselves or ask and represent themselves, so that it goes to the parent. What about in mental health, where you have an adult who has a fairly serious behavioral issues and can't really ask the questions for themselves? And there's so, it appears to me, much control of the mental health intervention treatment areas that very much limit the communication about what is the best drug for controlling what's the best mood stabilizer for my son or daughter or whatever it is, and then it's an adult son or daughter, and it's like, how can you do patient-centered care with individuals who are very vulnerable and unable to voice for themselves, and yet are viewed by society as making the decisions? It's that informed decision-making process. I don't know.
Yeah, sounds really challenging. I don't have
Yeah.
no experience, but I guess my advice would be that, you know how powerful the internet is,
Yes.
that there probably is some movement somewhere that's addressing those issues.
Mhm.
And there are probably grassroots, and people who are interested and passionate are probably going to make some movements in that area, is my guess, but I don't know. Any other questions? Yes?
Yeah. I'm trying to figure out how to phrase it before I say it out loud, but,
It's okay.
okay, so, we have a daughter with special needs, so we see a lot of different specialists. And, most of our specialists, I'm thinking through them as you're going through this, and absolutely do subscribe to this philosophy. I'm very pleased with that. But we have a couple who we don't see very often, but, who are very good at their job, but their bedside manner leaves a little bit to be desired, And so how do you marry these two? And I mean,
Yeah.
figure out how when somebody's just, okay, that's their personality and they don't know how to give that back, or are they being brusque and, no, I don't want to listen to what you have to say. I mean, am I being clear? I don't know if I'm being clear exactly.
No, it's hard. One thing that I might suggest is when you have a special needs child or an adult who has multiple needs, is the medical home, as was mentioned before, you know what the medical home is? It's related to this. It basically means that the primary care provider whether it's pediatrician, family internist, whatever, really is very involved with all of the specialists. And do you have your
Ours is-
pediatrician? Okay.
Yeah, yeah,
So I think that's who you go to.
okay,
Because there could be choices,
right.
and so they are really knowledgeable. They know what you're talking about. And when you talk to them, they'll know that.
Yeah.
They know it from their experience, they know it from other parents. And so they'll say, okay, well, how about going to another specialist, whoever is, but if there's nobody here, depends on how strongly you feel. I mean, there's choices out of town too,
Sure, sure.
at other centers.
Okay. And our primary is amazing, so, and he's
Okay.
very much this, so.
There you go. So
So
I-
we love
I-
him, and we, you know,
I think that's where you go.
okay.
Good question, yes?
I have a question about just the changes that are happening in healthcare right now. Not all that long ago, pretty much, everybody who was practicing in a private practice kind of setting. So all of the physicians were doing their own billing and so forth. Most of the ones that weren't were in medical schools, for example, where they were salaried. But that is really changing, and it's changing pretty rapidly. In Scotts Bluffs, for example, there are practically no private practice physicians. They are all being salaried at this point. What's the effect of that? When what you get paid no longer depends on how many patients you run through in the course of the day, or does it still, because that same pressure exists from the entity that you work for?
Really good question. I think the answer probably depends on what the group practice is. But I think overall it's probably good. Because this disadvantage that I went through with the time and the volume of patients, and it's easier to order a test than talk to the patient and so on. Well, now with patient-centered care and with the group practices that are out there, we are actually evaluated on different things, patient satisfaction being one. So if you have this, your patient satisfaction is going to go much higher than if you're going in and brusque and ordering tests and whatever. I think there's probably, it's better. We are salaried at different, the groups that we have, like my particular group is academic, so we have a score where if we're doing research and we're doing teaching, we get points as opposed to seeing patients. Some people in our healthcare system still have a problem with that because they pay the bills. But the medical school loves it. So we have two different ways to getting paid from medical school and also the hospital practice group. But it's fairly complicated in mine, but it's just, I'm just giving that as example, as I think we are getting reimbursed for things beyond the actual billing of what we're doing, charging. And so I think it's good.
So with all of the rumble around the country of people who are so vehemently opposed to the Affordable Care Act, that is one of the things that is moving us more toward salaried physicians and group practices and that sort of thing. And what I hear you saying is that is probably a vehicle for better outcomes. But we don't have any voices that are saying that loudly enough or effectively enough to get through to the gripers.
Well, one of the things about the Affordable Health Care Act I personally was disappointed in is it had some of this in it and was taken out. Because and maybe it was too early, I don't know. So I think there's still some chance maybe of building this in and more. But I think it's going to be more. I think it's going to grow. I think people are going to see the benefit, especially the lower cost part of it. I think we just need to experience it on both sides, patients and they need to understand that it, like you are tonight. I don't know how you get the word out beyond experience, but there needs to be more understanding on the basis of both sides. I think it'll grow. Yes?
Yeah, it seems to me like as society in general, intercommunication increases, then it has to grow because the opportunities for autocratic, dictatorial demagoguery by doctors would have to, in general, decline. And as information is shared within the medical, within society, et cetera, just through the nature of things in the big picture. So, but if you're a physician, you're Hippocratic oath or something, do no harm. Well, to do no harm, in essence, you have to try to do everything you possibly can. Make every test, do every surgery, do everything you can, because that's the only way to do no harm.
Well,
but if you're, if under this, you maybe ask, well, maybe I should focus on doing doing something that produces improvement.
Yeah, that's a very good point on the improvement, and very good point about the demagoguery of physicians. I would disagree with you a little bit on the harm part of it, because you can do harm by not operating, and you can do harm by operating. So that's really where it comes into.
If you're autocratic, you can be invasive.
Yeah. So let me. Do you know what a class 1, class 2, and class 3 indication for a procedure is? Okay. So class 1 indication for procedure is everybody agrees it's indicated. The example I use a lot with my patients is if you have appendicitis, there isn't anybody who says you shouldn't get that appendix out. That's class 1. Class 3 is, give you a really absurd example, is you have a headache and somebody says you need brain surgery. I mean, ridiculous, right? So everybody agrees that that's not the thing to do. Most of what we do is class 2, which means that you take all the information and I've had many patients in this where it's not a class 1 or it's not a class 2, but it's okay if you do and it's okay if you don't. A lot of that. There are a lot of physicians in healthcare who take a lot of things in class 2 and say, you need this. That's the physician center. As opposed to, here's the results, success rates, here are the complications, and what is best to you? What matters to you? You give that everything to one patient, they're going to choose to do nothing, or the medical part, or they're going to do a procedure that's different.
Well, it's the physician taking the effort to scan the feedback, well, which is, it's all about communication. It's communication and feedback from sociological or how do you say it? Looking at the studies of positive results.
The data. Yeah, the data. So our job, I think, is to provide the data, the evidence-based data, and different patients take that information and they decide differently depending on what matters to them. It's a big difference. So that class 2 is really depends on where you are in your life. It depends on your experience. It depends on philosophy. It depends on lots of different things. Yes?
It also sounds though like the physician has to learn to be okay with whatever the choices of the patient, even if it's not one they would choose.
Yes.
And that takes a fairly high confidence on the level of the doctor to be okay with that, whatever that is, you know, and I feel
It's
like.
very insightful. Yes, because it's hard for us. When we do a procedure that we know is good and relatively safe, and we enjoy doing it because it gives us a thrill and whatever, when the patient doesn't want it, and it's fine not to want it, but it's sometimes hard to turn that away. So if they turn you down, just what you're talking about, that's exactly right. That also goes into second opinions. I wanted to talk about that a little bit. So that's also a confidence thing. I love it when patients ask me for a second opinion because I just feel that that's a really good example of patient-centered care. They're really involved with that. Sometimes second opinions has been more of a negative thing. Like there's a disagreement and maybe the health provider was like not taking their opinions, like go get a second opinion sort of thing. Totally different way of looking at it, as opposed to how about a second opinion? I'll do everything I can to send you to wherever. The problem with second opinions are you need to go to a second opinion that's really good. Not somebody just down the street that you heard from your neighbor is a good doctor or whatever. I mean, you really need, and that's where, if you really trust your person that you want a second opinion about, and if they're confident, they'll be right with you. This is where you need to go, because this is the best for this particular thing, and so it tears at you a little bit if they end up going there because you know maybe you can do it or whatever, you have personal. But if you really look at what's best for the patient, that's what they need to do. Yeah.
What's the liability of letting the patient choose what they want to do for the doctor, and does that weigh on the opinion and the approach in that sense? Like if you say they need to have this procedure and they choose not to do it, does the family have any kind of do this? So they just fill out forms for waivers and all that kind of stuff, and then the family has no reconciliation. There's no way to come back on the doctor.
I don't think the only time maybe that will come into play is if there is an actual guideline that's been published that everybody, all the experts and all the evidence of information says this is what you should have done. Kind of like the appendix example or something, maybe not if they're acutely ill, but it's just everybody agrees. And they find somebody, they go against that and they find somebody who will go against that. There could be something there, but I would think it would be on the other person as opposed to you. So if I'm understanding your question right,
Well,
I
mean,
don't think so.
It doesn't, there's no way for them to be hurt by a patient or a parent choosing a different route than what you would suggest, right?
Yeah.
So it makes absolute sense that they would let the patient decide if there's no harm that can come to you for that.
Yeah, I don't think so.
I had a doctor that said, Chris, you nearly died from this, of course you want to do this, and I said, no, I don't want to do that. And because we fundamentally disagree on this, you're no longer my doctor. And so I went and found a different doctor. But he was very adamant about the fact that I needed to do this, and if I didn't do this, I was stupid. And if I'm that stupid, then he should just make the decisions for me, kind of a thing. And it wasn't a life or death situation, you know, and he seemed to think it was. And it was like, no, it wasn't. And I get to make that decision. So I think he thought that if he didn't convince me that that was a thing, that somehow he'd be even morally liable for not doing whatever he could to help me. Because he was adamant about it. And I was like, it's not going to hurt you to let me make the decision. And he just wouldn't let me do it.
Yeah, there may be some legal or whatever in their minds that would be in the background of why they acted that way. But I think in this day and age, if you just document everything, and this is the reason that I recommended such and such, and they chose not to, I mean, that's, yeah. So I don't think it's really an issue. A lot of questions? Okay, thank you.
Thank you, John.